Very good evening and a warm welcome to all of you. And this is Kushbu from One Learning. And on behalf of entire One Learning team, I welcome you all to One Talk Show. And One Talk Show, we have started from this month. And this initiative we have specifically taken, we wanted to choose some random topics and do some, educational activity, which is actually going to be monthly basis. And since this was the first time we were starting, so we have taken a lot of feedbacks from the lot of people. So many people actually have raised this request, to do some session on the ectopic gestation, and hence, here we are. And today's session topic is ectopic gestation diagnosis. So we will be, going through the role of ultrasound in ectopic gestation, how to diagnose and other clinical correlation, where we have a very good faculties with us. And it's my great pleasure to introduce our mentor, Dr. Manju Virmani, and Dr. Satya Senthil is there with us in this live session. And Dr. Manju Virmani is a consultant radiologist and practicing in Delhi, Handa Imaging Center. And Dr. Satya Senthil is a consultant sonologist and practicing in Spring Shadow Clinic in Coimbatore. And both of these faculties are carrying a lot of passion towards teaching and focus themselves towards the women's health segment. So it is like, be it gynecology, fetal medicine, and Dr. Manju is doing a lot of cases on breast as well. So we have a very good expert faculties with us. So let's try to learn related to the ectopic gestation topic. And meanwhile, we have also collected a lot of requests from a lot of people, related to the gynae ultrasound. So here, we are going to launch soon one gynecology ultrasound course, which will cover each and every topic related to that. So basic, starting with a very basic TBS scan, and then how to do the normal TBS scan and go for the further abnormalities. So I will be actually going through the complete course module later this presentation. So with this, I would like to request Dr. Satya Senthil to start the session. Over to you, ma'am. Thank you. You are on mute, ma'am. Please unmute. I can't hear you, ma'am. You just... That's okay, ma'am. That's okay. Just open your... Yeah. Now I can hear you. Yeah.
Yeah, you're able to hear me?
Perfect. Perfect. Yeah. Good to go. Yeah.
Okay. So good evening all. Today, let me take you through diagnosis of ectopic pregnancy by ultrasound. So this topic will be of interest for people who do ultrasound and also for people who manage medical emergencies. So before we start through, let me go through the disclaimer. The images posted in this presentation is not a subject of copyrights violation. The images were collected over the last 1 year between June 2021 to June 2022. My special thanks to Dr. Sonal for sharing some of her images to be incorporated in the presentation. The presentation is intended for educational purpose only and not for commercial use. So now let me start with ectopic pregnancy. When a pregnant woman in her early weeks comes to us with abdominal pain and bleeding, the first differential diagnosis which you should think of is an ectopic pregnancy, where there is implantation of fertilized ovum outside the uterine cavity. Even though the incidence is only about 1 to 2% of pregnancy, it is important for an early diagnosis because of its complications of tubal rupture in 15 to 20% of cases. So we should be aware of the risk factors for ectopic pregnancy because we are going to order for an early ultrasound in these women who have undergone in vitro fertilization, prior ectopic pregnancy, tubal injury or surgery, including tubal ligation, pelvic inflammatory disease, chronic salpingitis, endometrial injury, or having an intrauterine contraceptive device, endometriosis, previous placenta previa, congenital uterine anomaly, history of smoking, past history of spontaneous or induced abortions, advanced maternal age, and history of subfertility. So the markers in ectopic pregnancy are serum beta HCG level, which increases at a slower rate when compared to normal doubling rate in 48 hours in early pregnancy. So when you find an increase of 50% or less in 48 hours, it indicates a non-viable pregnancy. It could either be an intrauterine or an extrauterine pregnancy. The discriminatory level of beta HCG is less than 2000 international units, where a normal early pregnancy may not be visible on ultrasound. A single serum beta HCG at diagnosis will help you with management, and a repeat serum beta HCG at 48 hours will be useful for deciding further management. Remember, progesterone is not included in the standard protocols for managing suspected ectopics. So what are the different locations of ectopic pregnancy? Tubal ectopic forms about 93 to 97%, of which ampullary ectopic are most common. They form 70% of tubal ectopic. Next is an isthmal ectopic, which forms about 12% of tubal ectopics, whereas fimbrial ectopic is about 11% of tubal ectopics. Interstitial ectopic is also a type of tubal ectopic, which is about 3 to 4%, whereas cornual ectopic, ovarian ectopic, cervical, scar, abdominal, and heterotopic ectopics are all very rare, less than 1%. So what are the different approaches we are going to use to diagnose ectopic pregnancy, both by transabdominal and transvaginal, ultrasound, because they are complementary to each other. So a transabdominal scan would give you a wider overview of the abdomen to detect early pregnancy in an elongated uterus, where if you do a transvaginal scan directly, you're going to miss out an early pregnancy, which is in the fundus of the uterus. You can use a convex probe or switch to a higher frequency linear probe when the uterus is elongated, or to pick up high placed ectopics, especially when the ovaries are high placed in the iliac fossa, and to pick up free fluid in the Morrison's pouch, which is the hepatorenal pouch. So now let me take you through the technique to identify ectopic by a transabdominal scan. So keep your probe in the midline in the suprapubic region. You are going to appreciate the uterus, the endometrium, the endocervical canal, and the vagina, and take a sagittal sweep from one side to another side. You will pick up one side of the ovary. You will appreciate the adnexal on that side. Come back to the uterus, and then you see the other ovary. Take a transverse section, look at both the interstitial region all the way up to the cervix and the adnexal as well. So, transabdominal scans can be done either with the full bladder or an empty bladder. Here is a woman with an empty bladder. Still the same maneuver. I can appreciate one ovary on one side, another on the other side, and a transverse sweep. As you do this, there is a high chance that you might pick up an ectopic pregnancy, which is high placed. So what is the technique to identify free fluid in the Morrison's pouch? Take your probe, keep it in the right hypochondrium, and where you will see the liver, ask her to bloat her abdomen, the kidneys come up, pushing out the bowels, and you see you can pick up free fluid in the Morrison's pouch. Even minimal fluid can be picked up at this region. So here is a woman with an empty bladder with urine pregnancy test positive. I do see the uterus. There's endometrium is empty. But you could see the right ovary and an echogenic ring. I'm going to take a transverse sweep here, and you're able to pick up an ectopic even on a transabdominal scan without full bladder. But if the patient is stable, and if the patient is stable, you can go in for a transvaginal scan because of the diagnostic sensitivity and the dynamic ability of evaluation. So here, the same patient, I'm going to look at the lesion that is an ectopic, and I can use my probe brusher or do a bimanual palpation, which I'm doing here, to appreciate that this is moving separate. This ectopic is moving separate from the right ovary. So whenever you have picked up a lesion, evaluate them in at least two planes. Now, going back to a transvaginal scan, the technique, you ask her to empty the bladder and then try to insert the probe through the vagina very slowly and then look at the screen. Don't squeeze out so that you can appreciate the endocervical and the endometrium, and then move side to side. As you do so, you appreciate the interstitial region on one side, on both the sides, a transverse section, then both the interstitial region all the way up to the body and the cervix. So from that, you move to the transverse section and then look at the interstitial region, the tubo-ovarian ligament, the ovary, evaluate it in two planes so that you would pick up lesions in the adnexal, come back to the uterus as a reference point, then move to the left adnexal and do the same maneuver again to pick up ectopics by the transvaginal route. So, and once you have mastered that technique, now let's go into what are the reliable signs of ectopic pregnancy. When you see an extrauterine gestation with a yolk sac, with or without an embryo, and with or without cardiac activity, that is a reliable sign to make the diagnosis of ectopic pregnancy. So here is an ovary, here is an echogenic ring. It is echogenic because of the chorionic tissue. You do see the yolk sac, a tiny little embryo with cardiac activity. So that's a video showing cardiac activity here. So when you see this, this is a live extrauterine pregnancy. It is 100% specific for the diagnosis of ectopic pregnancy. Here is another woman with an echogenic ring, with a faint yolk sac and an embryo without cardiac activity on color. So this is also 100% specific for the diagnosis of ectopic, but these signs are not seen in 15 to 35% of ectopic pregnancy. Hence, we have to look for positive sonographic signs in the uterus, tube, ovary, and the peritoneal cavity. In the uterus, we look for all these signs. Let's go through them one by one. So when a woman comes to us with an urine pregnancy test positive or a beta HCG positive, then when you look at the uterus, the endometrium might be empty without an intrauterine pregnancy, or you might pick up a thick echogenic endometrium. That is when you need to carefully look at the adnexal. Or else, you might even appreciate a pseudo-gestation sac, which is a misnomer because this is not a gestation sac. It is just a small amount of intrauterine fluid collection. The shape can be irregular because of the endometrial peristalsis. The edges are pointed, as you can see here. They are centrally placed and they display the anterior and posterior endometrium. They can sometimes be filled with echogenic debris, which can resemble a pseudo-embryo without cardiac activity. A pseudogestation sac is also called the residual cast, and if it can be seen in 10 to 20% of ectopic pregnancy. So another sign is an intradecidual sac sign, which helps to diagnose early intrauterine pregnancy before the yolk sac or embryo appears. So that's an endometrium. You see an early gestation sac, an echogenic area, or a fluid collection with an echogenic rim, which is seen in the thickened endometrium on one side of the uterine cavity. So that's a 3D showing you a cystic area with an echogenic rim. If you see this intradecidual sac sign, it means there is a 60% chance that this can turn out to be an intrauterine pregnancy. So this should not be confused with a cystic area in the endometrium without an echogenic ring. So the clue is the echogenic rim around it. So another sign is a double decidual sac sign where you see an intrauterine fluid collection with an echogenic rim, and that is eccentrically placed either in the anterior or the posterior endometrium. In this case, it is implanted in the anterior endometrium. So you see two lines, two echogenic rings posteriorly formed, one by the basal layer of the endometrium. The central line is a functional layer. Then the third line is formed by the gestation sac. So three lines giving you two echogenic rings. If you see this, then there is a 53% chance of an intrauterine pregnancy. So now let's move on to the positive sonographic signs which you see in the tube and the ovaries. Let's go through them one by one. So here is a uterus. I don't see a sac in the endometrial cavity. That's an ovary with a corpus luteum. But by the side of it, you see a cystic area with an echogenic rim. And let's look at this video. I'm trying to give pressure, pro-pressure. You could see that's a small cystic area with an echogenic rim moving separate from the right ovary. So this is a simple adnexal cyst. But if you see that, there is still a 10% chance of this being an ectopic pregnancy. Whereas if you see a complex extra-adnexal mass, here is the endometrium, that's an echogenic mass, but on another plane, you could see it is much heterogeneous, complex, and with echogenic fluid with peripheral flow, and you could see there is a negative beak sign, which I shall explain shortly. And I'm trying to once again give pro-pressure, but I'm not able to appreciate this moving separate from the ovary, because when there is hemorrhage, this ectopic can be seen adherent to the ovary as well. But when you see this sign, there's a 95% chance of this being a tubal ectopic if there is no intrauterine pregnancy. So you can sometimes find an intra-adnexal mass, and they are most likely corpus luteum, which has irregular thick walls with crenulated inner margins with echogenic debris. But around it, can you see ovarian tissue? You see follicles there, and this is called the beak sign or the claw sign. Now look at the schematic diagram. Imagine this is a corpus luteum. This is an ovary. You see tissue engulfing the mass. So this is arising from the ovary, and with peripheral flow, on pressure, this mass is moving with an ovary. So moving with the ovary. So it's an intra-ovarian mass, most likely a corpus luteum. Sometimes we do see a solid hyperechoic adnexal mass. If you see them, then it is still a possibility of ectopic, but it's a non-specific sign. Remember, you should be able to differentiate from a pedunculated fibroid, which moves on pro-pressure. Look for other fibroids to give a clue. And on color, you might pick up a vascular pedicle from the uterus. Here is another sign, which is a tubal ring sign. That's a tubal ring. It resembles a bagel, isn't it? That is why it is called the bagel or the blob sign. Here you could see, then in this video, you could see there is a negative beak sign telling us that's a negative beak sign that it is not arising from the ovary. And on pro-pressure, this tubal ring is moving separate from the ovary, telling us that this is not the corpus luteum, whereas this is a tubal ring sign. And if you see them, there is a 95% chance of this being a tubal ectopic. So on color, you will see the ring of fire sign, that is peripheral flow in both tubal ectopics and corpus luteum. So when you see an absence of flow on color Doppler, you are not going to exclude, absence of flow on color Doppler does not exclude an ectopic pregnancy. So now let's move on to the peritoneal cavity. When you find free fluid in the pelvis or echogenic free fluid in the pelvis, that is the hemoperitoneum with a positive beta HCG and an empty uterus, then that is 70% specific for ectopic pregnancy and 63% sensitive for ectopic. But it is not specific for ruptured ectopic because these sign is still seen in 37% of intact tubal ectopics, and you also see free fluid in the Morrison's pouch. So here is an endometrial cavity on 3D. I don't see an intrauterine sac with a positive beta HCG. I could appreciate an echogenic mass here with peripheral flow and with low resistant trophoblastic flow pattern. And this video, it's very important to go for a transvaginal scan for the dynamic evaluation. You can see this echogenic mass moving separate from the uterus and the ovary on pro-pressure, positive sliding organ sign, telling us that this is a tubal or an adnexal ectopic. Sometimes you can pick up an echogenic ring like this, but make sure that you evaluate in two planes before you conclude on ectopic, because if it elongates, it could just be hydrosalpinx, which is thick wall, mimicking an ectopic pregnancy. So from tubal ectopics, let's move on to interstitial ectopic. Here, the endometrial cavity is empty. You see a gestation sac. I see a yolk sac, so I know this is a gestation sac, but it is laterally placed in the interstitial part of the tube. And you don't see myometrium all around it, or it can be surrounded by less than 5 mm of myometrium in all imaging planes. Once I've evaluated on 2D, make sure you do a 3D so that you can appreciate the interstitial line sign, which can also be picked up on your 2D. The sensitivity is about 80%, specificity is about 98% when you see an interstitial line sign. So here there's a larger ectopic here with a yolk sac and an embryo without cardiac activity. Here is an endometrium which is empty, and this is exactly in the interstitial portion. A 3D showing you that this is an interstitial ectopic, but with a yolk sac and an embryo. So what can the errors be in the technique? When you take a sagittal sweep, remember that you take a sweep so that the uterus disappears. See both the interstitial region on sagittal section. Also make sure you evaluate in another plane, a transverse section, and reach up to the fundus of the uterus. It's important to evaluate in two planes. If you cannot reach the fundus, especially in elongated uterus, use a special couch or keep a pillow underneath the pelvis, or ask the patient to lift her pelvis so that you reach the fundus of the uterus. So once you have evaluated on 2D, we have confirmed by 3D. If you have this facility, to avoid misdiagnosing an early intrauterine sac, an angular pregnancy, or degenerated fibroid, or an adenomyoma, and you can also use MRI if you are in doubt. So here is an endometrium which is empty. I do see a cystic area with an echogenic rim. It's a tiny cystic area in the interstitial portion, but I'm not able to appreciate the interstitial line at all here. So make sure you ask for a rescan to find out whether this turns out to be an early intrauterine or an interstitial ectopic. So here is a mid-sagittal section of the uterus. I do see a thickened and echogenic endometrium. I don't see a sac. So do not conclude that there is an ectopic pregnancy here. Try to, as I move to one side to another side, I did pick up a gestation sac, both on sagittal and transverse. And this is a video showing you that there is a sac here laterally placed in the lateral superior angles of the uterine cavity, nicely shown on 3D. So this is an angular pregnancy. So this is a twin pregnancy, which is also placed laterally. So that's an angular pregnancy. Remember, angular pregnancy should be considered potentially viable and may be managed to term. So here, let's see how we can differentiate an angular pregnancy from an interstitial pregnancy. So you do see a sac which is laterally placed, but I can see endometrium all around it on 2D and 3D. Whereas in the interstitial pregnancy, I see the interstitial line sign, the endometrium and the sac are separate. Then angular pregnancy is medial to the round ligament, whereas an interstitial pregnancy is lateral to the round ligament. So look for the surrounding endometrium sign to diagnose angular pregnancy and interstitial line sign to diagnose interstitial pregnancy. So you cannot reliably distinguish between the two using imaging alone. Diagnostic laparoscopy may be the final step where you will find round ligament displaced lateral to the pregnancy bulge in angular pregnancy, which is 100% specific and 80% sensitive. So here is an example of an interstitial ectopic, which you've already seen the image, but the mimicker is a cystic area with an echogenic ring with peripheral flow, and this is on 3D. So this was a case of could be a degenerating fibroid or adenomyoma. How are you going to differentiate it? Look at the interstitial portion slightly away from it, and you will see that the beta HCG is negative. And ask for the clinical history of cyclical pain in case of adenomyoma or presence of other fibroids in the uterus. Here is another case where I'm taking a sagittal sweep. I do see cystic area with an echogenic ring, and on 3D, I see a cystic area with an echogenic ring at the place very close to the interstitial region, and it is disturbing the junctional zone as well. Another 3D, as I walk through, you could see I can pick up another cystic area in the myometrium. So this is not an interstitial ectopic, whereas this is a case of adenomyoma. So don't jump into a conclusion when you see a cystic area with an echogenic ring. Try to place it on 2D and 3D. So this is a transabdominal scan. I did pick up an echogenic ring. It is very close to the lateral aspect of the myometrium. I don't see the myometrium around it. On 3D, no intrauterine. I don't see it in the interstitial region. But on 2D, I could well appreciate that's a ovary, that's a uterus. Cavity is empty. I see an echogenic ring with a yolk sac. So this is definitely an ectopic pregnancy. But is it interstitial or is it an isthmal tubal ectopic? The differentiation is going to be by the positive sliding organ sign. So I'm going to push in. I'm going to give bimanual palpation. You can see this echogenic ring moving separate from the myometrium and the ovary. So this is not an interstitial pregnancy which will move with the myometrium. Rather, this is an isthmal tubal ectopic pregnancy. Now let's move on to a Cornual ectopic. Remember, Cornual pregnancies and interstitial are both different entities. Cornual pregnancies are those implanted in the horn of an anomalous uterus. It could be in a horn. It could be seen in the rudimentary horn of a uniconvex uterus, or one of the horns of a bicorporal uterus, or on one side of a septate uterus. So here is a uniconvex uterus. Yes, it is uniconvex because you see a single interstitial portion and you see a sac. So this is an intrauterine pregnancy, not a cornual ectopic. But if you see a rudimentary horn with the myometrium and the cavity and a sac within the cavity, and if it is attached to the main body, then this is considered to be a cornual ectopic. So this is a bicorporal septate uterus, and you do see pregnancy in the left horn. That's on 3D, and this is also a case of Cornual ectopic. Now let's move on to a heterotopic pregnancy. When you see an intrauterine pregnancy, we are happy that there is an intrauterine, but remember, look for coexisting ectopic pregnancy, especially in IVF pregnancies, where the risk of heterotopic pregnancy is very high, which is about 1 to 3 in 100. Whereas in non-IVF patients, the risk of heterotopic pregnancy is about 1 to 30%. So here is a video where there's a live intrauterine with a non-viable extrauterine pregnancy. So this is a case of heterotopic pregnancy. Now let's move on to ovarian ectopic. So here the uterus is empty. You see a wide echogenic ring with an internal anechoic area. On the ovary, you might see a yolk sac or an embryo within it. But when you try to move it, it moves with the ovary. So there's a negative sliding organ. On in color, you will see a peripheral flow. Or if you have picked up an embryo, you will see heart pulsation. But remember, before you say it's an ovarian ectopic, you should look for corpus luteum on the same side of the ovary. And that corpus luteum, what you can see here, will not have an echogenic rim compared to the echogenic ectopic. So remember, ectopics are more echogenic than ovary in 77 to 88%. Ovarian ectopics are difficult to differentiate from corpus luteal cysts. Tubal ectopic pregnancy is stuck to the ovary, a second corpus luteum, ovarian germ cell tumors, and other ovarian pathologies. So these are all images of corpus luteums which can be misdiagnosed as ectopic. This is an intra-ovarian corpus luteum. We've already looked at the image. Whereas here, this is an exophytic corpus luteum. Whereas here, we do see an echogenic rim. So this can be most likely misdiagnosed as an ectopic. But in these cases, look for another corpus luteum there. See whether it is less echogenic. Only then this can be taken to be a ovarian ectopic. Otherwise, this was a case of a corpus luteum. And in all these cases, you do see the ring of fire appearance. So corpus luteum can be more echogenic than ovary in 3% of cases. So now here you could see an echogenic ring. That's an ovary, but you could see this is not centrally placed within the ovarian parenchyma, but it is seen by the side of the ovary with a peripheral flow. Now let me try to do a dynamic evaluation. Even though it is by the side, on a dynamic evaluation, I'm not able to separate it completely from the ovary at all. So this was a tubal ectopic which was adherent to the ovary because of hemoperitoneum and not an ovarian ectopic. So remember, tubal ectopics are more common than ovarian ectopic, but we have to try to differentiate as much as possible. So here there is a negative sliding organ sign saying that it could be an ovarian, but this was an adherent tubal ectopic. So two echogenic rings in the ovary. So could it be an ectopic? Another is a corpus luteum. Remember, ectopics are more echogenic than the corpus luteum. So here, this case had two corpus luteum because it was a stimulated cycle. So sometimes, very rarely, ovarian pathologies can mimic ectopics. So this was a case. I did see an echogenic mass here with a little bit of shadowing. I was thinking, was that a cystic teratoma? But can you see there is flow within that? And I'm trying to move it. This mass is not in the adnexa. It is moving with the ovary, but I don't see any hemoperitoneum, no ecogenic fluid, and also blood color flow within the echogenic mass. So some ovarian pathologies can mimic ectopic pregnancy. So ask for beta HCG before you conclude, and also ask for a rescan. Now let's move on to a cervical ectopic where the endometrial cavity will be empty. You see a sac below the internal os. How do you say this is an internal os? That's where the uterus takes a turn. You will have your flexion there at that point. Sometimes you will see, if it is an anteverted uterus, you will see the bladder coming up at that level. And on color, use color. And then if you move to one side, you see the uterine artery there, which tells you that this is a point of internal os. When the sac is larger, you can see the cervix can be barrel-shaped, and as you move it, you will not see the sac moving within the cervix, and there will be peripheral blood flow. So here was another case where how do we differentiate a cervical ectopic from an abortion in progress? If you see a sac-like structure there, or a collapsed structure, or an echogenic mass in the endocervical canal or in the lower endometrial cavity, and there will not be blood flow around the sac. And if you look into this video, you would see this echogenic mass is moving, sliding within the lower endometrial cavity. It can also move into the endocervical canal. So this was a case of abortion in progress and not a cervical ectopic. Your tiny cystic area, once again in the cervix, but I don't appreciate an echogenic rim at all, no peripheral flow. And when I try to move it, it is not moving within the endocervical canal. So non-echogenic rim is most unlikely to be an ectopic. And on 3D, I could see something within the endocervical canal. So because you've seen something within that, do not think it is a cervical ectopic, because of partial volume in 3D, which is an artifact, a small nephrotensis, which is outside the ovarian stroma, can be seen within the endocervical canal. So it is just a nephrotensis. Be very careful. Look at the adnexal to make sure that you've not missed out an ectopic pregnancy. Now let's move on to a Cesarean scar ectopic pregnancy. You see this endometrial cavity is empty, the endocervical canal is empty, and you see a scar there. It might shadow sometimes, or you might see a small indentation at that point. So at that point, this is an anteverted uterus. The fundus is facing anteriorly here. If you see a gestation sac or a solid mass of trophoblastic tissue at the level of Cesarean scar with a very thin myometrium or an absent myometrium between the gestation sac and the bladder, or you see the myometrium thickness less than 8 mm, mostly it is about less than 5 mm. And on color, you see a high velocity flow, that is the peak systolic velocity more than 20, your PI less than 1, RI less than 0.5. If you see so, that is a case of Cesarean scar ectopic pregnancy. So here is an example of a retroverted uterus. The fundus is facing posteriorly. So here is the bladder. This is the anterior myometrium, and you do see the scar here. So here I did see a cystic area. The uterus is parallel to the beam. So I'm not able to appreciate the echogenic rim well. See that on grayscale, get the structure perpendicular to the beam. So I'm going to push in with my probe. As I push in, and you know this is perpendicular, I can appreciate the echogenic rim much better. On color, you do see peripheral flow. And as you move it, there will be an absent sliding organ sign. So do not mistake a scar ectopic for an isthmocele, which is just a fluid collection in the LSCS scar defect. You don't see the echogenic rim at all at that point. So we saw a gestation sac in the scar, whereas you can also see an echogenic or a heterogeneous mass in the LSCS scar region, which is projecting out of the serosa, and it can also invade into the bladder. So these masses should not be should not be mistaken for a degenerated fibroid. Look for previous history, look for previous scans, and look for other fibroids in other location of the uterus, and ask for beta HCG. So there are two different types of Cesarean scar pregnancy. We are going to differentiate by the depth of invasion. If you see a sac implanted deeply into the scar defect and reaching up to the serosal lining, possibly into the bladder or the abdominal cavity, there's a high risk of uterine rupture and hemorrhage. Whereas the second type implants in the scar but grows away from the serosal lining and towards the uterine cavity. So there is a system to categorize Cesarean scar ectopic into 4 grades based on ultrasound finding. Grade 1 is when the sac is implanted in less than 1/2 of thickness of the myometrium, whereas grade 2 is when it occupies more than 1/2 thickness of the myometrium. Grade 3 when the sac bulges out of the overlying myometrium and the serosa. Grade 4 when the sac becomes an amorphous tumor with rich vascularity. So now let's try to differentiate a Cesarean scar from a cervical ectopic pregnancy, a low place intrauterine sac, and a spontaneous abortion in progress. 13% of reported case of cesarean scar pregnancy was misdiagnosed as intrauterine or cervical pregnancies at presentation, and ultrasound did have a sensitivity of about 86%. So this is a Cesarean scar ectopic. This is a cervical ectopic. How are we going to differentiate between the two? The sac here is in the anterior lower Cesarean scar. The overlying myometrium can be thin or absent. The cervical os will be closed. If you do see an embryo, you might see an embryo with cardiac activity. Whereas here, the gestational sac in a cervical ectopic is within the cervical stroma, very close to the cervical canal. The myometrium overlying it will be normal thickness, closed cervical os, and you might see an embryo with cardiac activity. So in both these cases, the sliding organ sign will be negative. Whereas if you want to differentiate a normal low place sac from an abortion in progress, in a normal low place sac, the sac will be seen above the internal os. We know how to find the internal os. The overlying myometrium will be normal, cervical os will be closed, sac will be regular. On color, you will see surrounding blood flow. You might see an embryo with cardiac activity. A sliding organ will be negative here. Whereas in abortion in progress, you see a sac in the endocervical canal. Myometrium will be, here is an anterior myometrium because this is a retroverted uterus, will be normal. Cervical os may be open. The gestation sac might be collapsed or irregular. No surrounding blood flow. And if there is an embryo, there will not be cardiac activity and it will have a positive sliding organ sign. An example of a low place intrauterine sac, which is well seen on a 3D as well. And as I move, you will see that there is a negative sliding organ sign. So this is not an abortion in sac. This is not abortion in progress. So the crossover sign is an ultrasound sign proposed to describe the relationship between a gestation sac, a Cesarean scar, and the anterior uterine wall, whether to find out whether the Cesarean scar pregnancy will progress to a morbidly adherent placenta. So you take a sagittal view of the uterus, draw a straight line connecting the internal cervical os and the uterine fundus, go through the endometrium, that is an endometrial line which is seen as a yellow line, identify the gestation sac and draw another line perpendicular to the endometrial line, which is a superior inferior diameter. If you see at least two-thirds of the SI line, the red line above the endometrial line, which is what you're seeing in both the images, then this is a crossover sign 1. Whereas crossover sign 2 is when you find less than two-thirds of the SI line above the endometrial line. That is, the sac is more within the endometrial cavity, which I'm not shown in this image. So a deficient myometrium in the Cesarean scar pregnancy with anterior displacement of sac more towards the utrovesical interface is a cause 1, which carries a poor prognosis, whereas pregnancies in Cesarean scar pregnancy developing into the endometrial cavity, which is cause 2, has varying degrees of placental invasion. You might have placenta accreta or preaccreta spectrums. When you find equivocal ultrasound findings in Cesarean scar pregnancy, you can offer non-contrast MRI, which will be a useful problem-solving tool. And remember, confirm before you go for a definite intervention. Finally, a word about the abdominal ectopics, where the intrauterine gestation sac is absent. There's an absent dilated tubes, absent complex adnexal mass. The gestation sac is surrounded by bowel loops, but separated from them by the peritoneum, and it moves widely when you give pro-pressure. In a clinically stable patient with abdominal pregnancy on ultrasound, MRI is a useful diagnostic adjunct in advanced abdominal pregnancy to plan surgical approach. So what is a pregnancy of unknown location? Your PULs are assigned when neither an intrauterine pregnancy or an ectopic pregnancy is identified on a transvaginal scan in the presence of a positive pregnancy test. So the possibilities in a PULs are, it could still be a very early pregnancy, it could be a non-viable intrauterine pregnancy, a complete miscarriage, or an ectopic pregnancy. When you find urine pregnancy test positive or beta HCG positive, no gestation sac on a transvaginal scan, what do you do next? You ask for serial beta HCG, do short interval repeat scan until you see an ectopic or an intrauterine sac, or until your beta HCG becomes zero in case of miscarriage. So you do your beta HCG first and repeat it after 48 hours. Then look at the HCG ratio. If the ratio is less than 0.7, 48 hours by 0 hour, if it is less than 0.87, it indicates a failing PUL. Whereas if the HCG ratio is more than 0.87, it could be an intrauterine or an ectopic pregnancy. So if the HCG ratio is more than 0.87, you are going to repeat beta HCG on day 7. Do it and also rescan and confirm whether it's an intrauterine or an ectopic pregnancy. Still, there could be a 2% chance of this being a pregnancy of unknown location. Remember, HCG ratio, which is the change over 48 hours, is a single best test for evaluating pregnancy of unknown locations. What are the complications of ectopic pregnancy, which we've already seen? Tubal rupture and lithopedion, which is stone babies, which may result when there are larger ectopics, failed ectopics, which have been left in situ. So a word about treatment of ectopic pregnancy. Management depends on location of ectopic and patient's hemodynamic status. Surgical management for tubal ectopics are open or laparoscopic salpingectomy or salpingotomy. Medical management would be methotrexate, either administered systemically or by direct ultrasound guided injection into the gestation sac. The contraindications for methotrexate treatment is ruptured ectopic, or when the mass is more than 3.5 centimeter with fetal cardiac activity or beta HCG level more than 6,000 milli-international units per ml, or if you find, or when you've gone through methotrexate treatment, you might see there is a paradoxical increase in the size of the mass on subsequent scanning. So this does not, the increase in size does not necessarily imply failure of methotrexate therapy. Remember, if you're going to install potassium chloride into the, you can also install potassium chloride into the sac by under ultrasound guidance as well for the treatment of ectopic pregnancy. So conservative or expectant management can be done in unruptured ectopic without hemoperitoneum or when there is an embryonic demise. So these are the references for you to look through, and thank you very, very much for a very patient listening. Thank you so much.
Thank you so much for a wonderful session, ma'am. Now I request Dr. Manju to share her screen. Ma'am, are you there?
Let me stop sharing.
Yes, yeah, please, yeah. So meanwhile, if you have any sort of questions, so please write it down, in the chat box. So once we will complete the session, we will do a quick Q&A session as well. Perfect. So we can see your screen, ma'am. But we can't see your video, ma'am. So please turn on your video, and we are okay.
The video is on.
Okay. Okay. Fine.
It's on. The video is on.
Okay. Perfect. Okay, ma'am.
You see me now? Okay. Even if you can't see me, doesn't matter. I think we've been through an excellent.
I turned my video.
Can you hear me, right?
Yes, ma'am. We
Okay.
can.
So, Pushpa, we've just been through an excellent presentation on ectopic.
Yeah.
Uh, I just picked up a few cases just to show where and how, when we start thinking in terms of ectopic, and how do we go about differentiating them from the other pelvic pain conditions. So, uh, so my first thinking is there are two patients, one 19-year-old and 25-year-old. They both presented with severe pain, very, very tender pelvic area. This 25-year-old was acutely ill, and so they both show a complex adnexal masses, which may be echogenic. They have small cystic areas. And this lady, the 19-year-old, showed significant free fluid, which was echogenic. And then there was fluid in the hepatorenal pouch. Uh, and also color flow shows increased vascularity. Now the thing is that this particular girl was not married. So first thing what you have to do is, either what I do is I ask the parents to go out. I asked the mother to step out. I asked this girl, are you sexually active? And then she did say yes. And I had to take the mother into confidence, call the mother back, because this girl was so severely, I mean, she was in such acute pain that she was screaming. And so this was, there was no beta HCG done. She was sent straight to the over surgery, and this turned out to be a ruptured ectopic, right side. Whereas this particular girl again was not married, and I asked her persistently, but she won't give the information. But this girl had a chronic ectopic. So we have to start thinking on these girls when they come to us, is that they may be sexually active, and we do take a history so that we can give a better decision. Now we've already been through the differential on eccentric gestational sag. The angular sag, we know that is superior lateral angle of the uterine cavity, medial to the uterotubal junction. Now here was one such patient. Now her history was that she'd had multiple missed abortions. So when she found out pregnant, I called her back. The sac is eccentric. You come back in 2 weeks' time. There was a yolk sac, there was an embryo, good cardiac activity, but it was still very eccentric. Now, this girl did not come back to me till she was told that she went somewhere else, and these people do that. She was told that there's no cardiac activity. That's when she came back to me, and it actually was there was a very, very thin overlying myometrium, and this patient was actually at the point of the rupturing, because by that time she had started getting acute pain. So one has to be careful, and Dr. Satya has already told us all this. And there's distended lateral angle of the uterine cavity, and there's a large, broad-based connection with the endometrium. Myometrial thickness surrounding the sac may be less than 1 centimeter. Cornual pregnancy, which we always use for these eccentric sacs, are only when the intrauterine implantation is in the anomalous or Mullerian anomalous uterus. Now, here was a bicorporal uterus with there was a live gestational sac on the right side, and this was a partial septate with a left horn cavity. I mean, sorry, a left gestational sac. And this particular patient actually had 4 missed abortions. The first time somebody sent her to us, we found that it was a unicornuate uterus. She lost her, she came back again, and she was pregnant again with this pregnancy in the horn, and she carried up to 12 weeks, and then we lost her. So I have no idea what happened to this woman. When there's an oh see, this was that patient which I just talked to. Okay, this image came on this side, sorry about that. So interstitial pregnancy, the implantation of gestational sac is in the intramural segment, interstitial segment of the fallopian tube. And there we see the classic interstitial line sign, which Dr. Satya has already explained us. And this was a follow-up, and this was at 10 weeks when there was no cardiac activity. She had to be operated immediately. And this patient again had a very eccentric sac, and we can see that this was outside the endometrial cavity. The cervical ectopic, the gestational sac with the decidual reaction and a hypervascular trophoblastic ring is seen in the endocervical canal. And like she said, we do the sliding sign, and if it is a cervical ectopic, it does not move as compared to a low the sac which either the patient is aborting out or is just a missed abortion. Those will move with the sliding sign. This was another 37-year-old. who actually again had a history of multiple missed abortion, failure to conceive. She conceived after follicle, and she showed us this double yolk sac sign and embryo, but there was cardiac activity. She was 37-year-old, but she refused to do anything. She comes back with a massive bleed at 10 weeks of pregnancy, and this was, we had already called it a cervical ectopic. And that's when she came back to just to reconfirm, because she had gone to a hospital where she was told that she needs to be, that this is an ectopic pregnancy. So C-section ectopic pregnancy, again, we've just had a very good talk on it, but so these account for less than 1% of pregnancies. They are more frequent these days because of increased frequency of C-sections and improved technology of the ultrasound imaging. It is of critical importance for early diagnosis because they can give uterine rupture, hemorrhage, loss of future fertility, and possible maternal death. And the sac is in the lower uterine segment in the C-section area, and there's an absent or a thin myometrium surrounding the sac, and we've been through the grading. But these are three different patients who I'm going to show you who presented with severe pain and bleeding. This was 34 years old, infertility treated, and she had secondary infertility because she had one child, and she had a pregnancy in the scar. She had fluid collection in the endometrial cavity, and 3D actually demonstrated it very well. This collection, which was more to the right of the thing. And this patient was immediately taken for surgery. This was the patient who came, who actually had very, very severe pain at night, and she was taken into the emergency room where they told her it's missed abortion, and they did try and do an MTP. They tried and evacuated the contents. She came the next day, and there it was a huge hematoma, large collection which had some vascularity, but no sac was seen. Endometrium was completely empty, and 3D actually showed it and showed this collection. So this was another patient with scar pregnancy. She was treated with uterine artery embolization. She did very well because she came back 3 times, and after the third time, it was completely cleared up. But this patient, good uterine artery embolization did help her. Whereas this patient came to us with massive bleed. I mean, she was just pouring. She had pain, severe pain, but her major problem, what she came to us, was where she was pouring. And there she showed a very thin myometrium. She showed a sac. She showed a lot of blood, which was going back and forth into the endometrial cavity, marked increased vascularity, and 3D did confirm all this. And this patient actually was told that they will have to operate her and she may lose her uterus, but she ran off. So we don't know what happened to this girl. Now, the other reason some these patients who sometimes present with pain is when there is spontaneous abortion. This was a 26-year-old woman who had actually lost her fetus. She came for the first time for a scan. There was a lot of blood which was seen as hyperechoic collection. And the larger the bleed, the poorer the prognosis. And this patient did have a viable pregnancy. This patient came with severe pain, no bleed, but there was again a missed abortion, and the pain was probably because the uterus was trying to contract to push this sac out, and this was a history with the amenorrhea of 11 weeks. Uh, Whenever we see the marked in this non-homogeneous texture endometrium and with lot of fluid collection, marked increased vascularity, these are retained tissue, and and whenever the thickness is more than 10 millimeters and increased vascularity like this, they need to be treated. They need a repeat DNC or whatever. Uh, because if and also these are the patients with increased vascularity who should get a follow-up done 4 weeks to make sure that they do not develop an AVM. And this is one example which is actually very interesting lady, 34-year-old. She came with severe pelvic pain. She was so much in pain, she was as if she is going to collapse because she looked very, very sick. And she'd had a DNC just less than 24 hours before. The next morning, she had such severe pain that she was referred to another physician. And This showed an empty sac but lot of complex looking area in the lower endometrial cavity, which was extending into the myometrium. And and during the real time evaluation, I could see actually the fluid going back and forth from this area into the peritoneal cavity. There was a little bit of fluid in the peritoneal cavity, but not too much at that time. And the color flow showed increased vascularity. So from the clinic, she went straight to the OT, where she had detailed products of conception. She had ruptured the lower uterine segment, and she also had a hematoma, which was all taken care of. She came back, and she was doing fine till about 4 weeks post all this. She comes back with a massive bleed and a negative beta HCG, and this is what her picture looked like. Again, endometrium looked all right, but there was a complex mass here which was extremely vascular, and this patient had a traumatic ABM. So the thing is that it's very, very important to follow these patients up so that they don't land up with him traumatic AVM. And this actually is interesting. The first time she was so thankful to the doctor. The second time she was cursing the doctor. Why was she not informed that she needs the ultrasound to confirm that she has not developed an AVM? Because when she came this time, she was bleeding a lot. So I think she went in for uterine artery embolization too. Now, the other time when these patients present is with diffuse pelvic pain. They may have fever, they may not have fever, but this particular patient, who was 24 years old, had acute onset of pain and vomiting, and she showed a complex mass which was separate from the ovary, and she showed significant free fluid. And her beta HCG was post this test. She had a beta HCG which was negative. Also, she was not married, but we did do a beta HCG which was negative. This turned out to, and there was marked increased vascularity on color flow, and this patient had PID. This was another patient who, again, similar history, but 35 years old, presented with a complex mass. We can see a lot of internal septation. We do see a tubular cystic focus with a lot of increased internal echoes, and color flow showed marked increased vascularity. So this was a tubo-ovarian complex, and this patient had a pyosalpinx. So and there was mild fallopian tube wall thickening as well. So this was pyosalpinx. This was another patient, 28 years old, who presented with the tubo-ovarian complex. Here also, again, we have the tubal component, but we do separate the ovary out. Here the fallopian tubes were thin walls, there were internal echoes, and this patient had an intrauterine device. And so that was her reason for getting a tube, forming this pelvic abscess. But if these patients, both these two patients are not treated, they can form tubo-ovarian abscesses, and then there is a problem looking after them. They can get further complications following those. Now, these are two different patients. One is 19-year-old and the other is 27-year-old with pelvic pain and abdominal distension, and both of them show a normal looking uterus, but there's significant free fluid in this particular patient who's 19 years old. Here there was extensive fluid with a lot of internal septations and loculations and thick and nodular peritoneum, and both these patients were of tuberculosis, which was diagnosed in these patients, both of them. Uh, this was a 32-year-old who presented with severe acute pain. So this patient had a large anechoic, predominantly anechoic, but there were low-level internal echoes, which one could see at the real-time evaluation. 3D showed a complete and distinct thin wall, regular margins, and both those ovaries were normal. So because the size was large, she was taken for surgery, and this just turned out to be paravarian cyst. Whereas this particular woman with a similar complaint, similar picture, a large cystic mass with internal echoes, and the 3D doesn't show too much information except that there are no intramural nodules or anything. And color flow is avascular. There was not much vascularity, and this surgery was a twisted cyst with fallopian tube torsion. And torsion leads to strangulation. So it's important to look for the blood flow, because initially the venous flow goes away, then later the arterial flow goes away. And sometimes because these tubovarian areas have dual blood supply, the flow sometimes we do see in torsion as well. Now, this was a 40-year-old woman, and she came with severe acute pain, 4 weeks amenorrhea, and she was sent. She'd already given the beta HCG at the hospital, and she had these complex-looking masses on both sides. So we know the probability of ectopic goes down. And her beta HCG was tested negative. She was treated conservatively. She was followed up in about uh, 4 to 5 days, and the configuration of both these ovarian masses had changed, and this was a hemorrhagic cyst. So she was diagnosed well, and in fact, it's interesting. Her husband argued with me because the table was busy and I couldn't take his wife immediately. But she was in acute pain. Until today, whenever she comes, she said, "Do you remember who I am? I'm the same lady." So hemorrhagic cysts can present as complex cystic structures. They have smooth capsules. The classic thing is the thin reticular lacy pattern. They may get fluid debris level. When the clot retracts, it forms curvilinear demarcation lines. They can settle at the bottom in the dependent portion, and generally these clots are avascular. This was a patient 37 years old with history of chronic pain but sudden onset of acute pain. Now here on the transabdominal scan, we can see a uterus, we see bilateral ovarian complexes, and this shows low-level echoes, which actually transvaginally gives a much better visualization of these, and this is classic endometriotic cyst. Also, this patient had a thickened fallopian tube which was surrounded by free fluid. There was significant free fluid in the pelvis, and on the left side also there was like a multiple cyst with a lot of increased vascularity. So this girl had endometriosis, and she had now, endometriosis, we know typically the typical cysts, they present a unilocular, they have ground glass echogenicity, they may have these wall nodularity, they may have fluid debris levels, they may be atypical when they're multilocular, they may have these retracted blood clots, which are these echogenic avascular areas, they may have these peripheral calcifications, which are generally more in the chronic chronic endometriosis. The color flow is generally avascular. The echogenic nodules are always avascular in them. And they are adherent to the uterine wall. And when it's severe, then we see both the masses which come together and they are adherent to the uterine wall and they adherent to each other, and that's called the kissing ovarian sign. The other things which are non-gynae cases, which are associated with acute pain, is acute appendix. Now, here's a 22-year-old woman with 6 weeks amenorrhea, had right acute pain in the right iliac fossa and recent onset of 4 years. She also had associated nausea and several episodes of vomiting, but there was no complaint of no urinary complaint, no hematuria or bleeding or vaginal discharge. And then she showed classic signs of acute on the ultrasound, she was sent for a pelvic, by the way. So one has to look on the other areas. If we find no pregnancy, no variances, ovaries looking normal, adnexal looking normal, then do look to rule out the acute appendix, where what we generally see is a non-tubular, non-compressible structure. In this case, it was measuring for 9 millimeters, and there was fluid collection surrounding it. So this patient had an appendix which had ruptured. Now here's another patient who was 30 years old, history of flank pain, hematuria, nausea, and vomiting. And she was actually sent for a pelvic ultrasound. So I'll go backwards how we picked up. We were doing a pelvic ultrasound and we found that the echo density, which actually was not shadowing, we did a transvaginal ultrasound, and it actually beautifully picked up a stone. Because we started with the endovaginal ultrasound, the uterus and ovaries are completely normal, and when we did the TVS, we found that there was a distal ureteric calculus. And then we went and looked at the kidneys, and this patient had hydronephrosis and a hydroureter. This was another patient who had pain in the right abdomen and pelvis, but she had severe hydronephrosis, which we can see, and she also showed a calculus in the lower calyx. Acute cholelithiasis generally do not have pelvic pain, but these two patients were just as a routine were sent for whole abdomen, and then we find that this 32-year-old had gallstones, common duct looks normal, and this patient who was 40 years old showed this thing called gallbladder calculi, but also showed a thin rim of pericholecystic fluid collection. So she had acute cholecystitis at the same time. Now, just to end, I didn't put in fibroids, as fibroid is another complication. We do see degenerating fibroids, and they do present with severe pain, etc. So I would like to end here, but I would like to invite you all. I should have asked Khushbu before if I can show this, but now I didn't ask her, but I would like to invite you all to this AFSAM, which is being held in Hyderabad. from November 11 to 13th this year. And the registration is all open. Thank you so much for your
Thank you, ma'am. And it's perfectly fine. So any educational activity, we can definitely showcase because it's definitely benefits everyone. So please stop sharing, ma'am. So I'll also share from my side. Just a second. Okay. So meanwhile, let me also take a few questions like which few people have already asked.
Am I off now,
Okay.
right?
Yes, yes, you are, ma'am. So just a second. Okay. So let me take that Q&A. Okay. So we have a first question from Dr. Usha: how to calculate HCG ratio? Yes, ma'am.
Hello, am I
Hello. Yes,
audible?
ma'am. How to calculate HCG
Yeah.
ratio?
So HCG, you take two HCGs on the day the patient arrives, first HCG, and after 48 hours. So take 48 hours first and then divide it by the first HCG. So that if it is more than less than 0.87, it is a failing tubal. If it is more than 0.87, then you ask her to take another HCG at 7 days and then rescan and say, find out whether there is an intrauterine or an extrauterine pregnancy. So it will be
Ma'am,
40
please turn
plus.
on your camera. Yeah.
Yeah.
Okay. Yeah. Perfect.
Yeah.
So, okay. And then second question is how to differentiate scar niche and scar pregnancy.
Scar niche will be a triangular cystic area with fluid. Okay. So when there is fluid, there sometimes as you give pressure, you will see the fluid displacing into the endometrial cavity. So that fluid can be easily displaced when you give pressure. But whereas a scar pregnancy will be mostly a round or oval cystic lesion with an echogenic rim with vascularity. An isthmus seal will not have any vascularity and you can displace it as you give pressure. So that's a way we differentiate between a scar ectopic from an isthmus seal.
Perfect. What is the tubal abortion and imaging finding of that?
So we cannot differentiate between a tubal abortion, but you might see a lot of echogenic fluid, and sometimes you might not be able to see vascularity. If we don't see vascularity, it does not mean this is not an ectopic, or is it a tubal abortion. So it's very difficult to differentiate. So that is why we just call it as adnexal ectopic, whether it is complicated or uncomplicated. When you see a lot of fluid around it, then we have take it to be a complicated adnexal ectopic, and when there is no fluid, we take it to be an uncomplicated ectopic. So it really need not be differentiated between the two, and look for beta HCG levels. If it is a tubal abortion, then it probably is going to come down. So look and also ask for a rescan in these women.
Perfect. Any more questions? I don't see any other questions. So you can just write down in the chat box, or maybe you can just raise your hand, like by clicking on speak. Okay, so if no questions are there, so let me introduce one course which we are going to launch from July month. And that is, of course, Dr. Manju Virmani and Dr. Satya Senthil will be the mentor for this course. And this course is actually on too much of demand because we have collected a lot of, feedbacks and suggestions from the doctors, and they actually require a lot of training in doing the TVS ultrasound, and then, of course, correlation between the normal and then abnormal ultrasound. So that's why I have actually requested Dr. Satya and Dr. Manju to design some sort of course which will include each and every topic related to gynecology ultrasound. So here we are actually introducing the modules, like we will be starting with the neurology, techniques, orientation, and then of course we'll be blending this with a little bit 3D ultrasound in the gynecology as well, Mullerian duct anomalies, gray scale, and color Doppler evaluation in sub infertility, of course, in the ultrasound anatomy of uterus, cervix, vagina, So basically, we are going to start with the very basic image optimization anatomy portion, and then we'll go, step by step, like how to find out the normal physiological changes in ultrasound, and then followed up with that lot of abnormal cases, including your IOTA guidelines and everything, the endometriosis and deep pelvic endometriosis, clinical application related to 3D ultrasound. So everything will be packaged in this, and we have just sent you that link to in the chat box. So please do visit that. If you feel like this particular course will help you in any way, do join us, and then our team will be actually after this meeting, like they will post in your email ID as well. So just have a look. And along with this online live session, we are also going to blend this learning with a 2 days hands-on workshop, which will be done like in Delhi at Handa Imaging, and then in the Coimbatore at Dr. Satya's place. It is also we may also do on the hands-on on the simulator, and also the observership is also open for the gynecology ultrasound. And post completion of the courses, we will be facilitating the the certification ceremony as well. So during the hands-on session only, we will actually distribute the certificate. So that's the flow of our course, and then I welcome all of you to just have a look and see the complete the topics, and what all topics we have covered. And if you have any doubt, our team is there to support. And this during this 3 months duration, we will be actually working with you closely, and then we have a one help desk. So suppose if you have any sort of doubt, so our mentors will be supporting you. So we will connect you with the the faculties and take out your queries. So, and also One Learning, we have also introduced a community section. So when you go to our website, you have a join community option. So that's a free community, free social community. You can join that community. We will be posting a lot of webinars and then, free session in that community. So this will actually anyways going to help all of you. So with this, if no other questions are there, so let's wrap up today's session. And thank you so much for joining us today. And if you have any sort of doubt related to this, or any kind of suggestion you want to give, do give us at info@onelearninghealthcare.com, and our team is there to support you. So thank you so much. Thank you so much, Dr. Manju and Dr. Satya, for supporting on this show. Thank you.
Thank you,
Thank
Kushbu.
you.
Thank you, ma'am.
Thank you.